Okay, so let's start. It's already 12, so it's a very special talk for me today because it's by Dr. Nargis. Just for a small and very informal introduction of hers, that is Dr. Nargis, and she's been with Sneha since 2009. I'm not going to tell the end date, though she's not in India right now, but she's always been associated with us and
Yes.
she's always been there. So I'm not going to tell that she was working from here till here. And she is a NDT certified therapist. She's an aquatic certified therapist, and she's done a lot other things. And she's a very nice therapist because whenever she's worked in Sneha, the patients still remember her very fondly. So Nargis, thank you for taking this up. And yes, so over to
Thank
you.
you so
I
much.
won't talk
Yes.
much.
Thank you so much. Okay, everyone can hear me clearly and see me
Yes,
clearly? Great.
Yes, ma'am.
yes, ma'am.
Okay, thank you so much, Purvi, for giving me this opportunity. As she rightly said, I have been associated with Sneha since 2009, and although physically I don't work there anymore, but still, whenever I get an opportunity from them, I love being involved with the institute. I love being around ma'am. I will just start sharing my screen before I say a little bit about more about myself. Okay. Okay. So I am a physical therapist. I am certified in NDT and aquatic therapy, and I had the opportunity to work very closely with Jane, who is an NDT instructor. I did my basic NDT in 2012. I did my advanced in 2015. And during this entire time, I assisted Jane in 3 of the basic NDT workshops, which is a very huge thing for me. So it was during these 3 workshops that I met Monica and Therese, who are 2 very dynamic and very versatile speech therapists. Most of the notes that I'll be sharing with you today are from them with their permission. I have also put in some videos and photographs of my patients whom I have seen abroad. So again, I would request none of you to copy this or record or take pictures. Okay, so without wasting more time, we'll move ahead. So the oromotor system from the perspective of pediatric physiotherapy. We will be going into detail of what the oromotor system is, how it develops, and what impact it has on us as physical therapists, and what we can do to help the oromotor system in our kids. So we will be talking about typical development, atypical development, assessment, a few treatment strategies, and what are the tools that are used. Please note this is more of an introduction. I'm not going to go into too much detail about everything because that is not possible with the time that we have right now. So take this more as a sort of basis for what you could do in the future. So starting with typical development. So the newborn is basically set up to feed. It's born with those instincts that, and whatever it needs to feed is already present. The physiological flexion that the newborn is born with provides the perfect base of support. The high rib cage, the chin resting on the rib cage is a perfect base of support that is needed for feeding. The tongue rests on the lower jaw and takes up most of the space in the mouth. And because of this, there is not so much of movement of the tongue happening in the newborn. It's more of an up and down movement. And that also is not an isolated movement. The whole mouth moves as a single unit at this time. The compact nature of the structures allows for the sucking which is happening. So it's not actual sucking movement that is happening because the structures are so compact. When the mouth goes around the source of your food, that is either the bottle or the breast, there's the closure that happens is basically because of the compact structures, which creates the true negative pressure, and that is how the sucking movement happens. The tongue is cupped at this time, and there is more of an up and down movement. The lips are not actively involved, again because of the compact structures, the fat, the thick cheek pads that you have. That is why the closure is happening. Yeah, that is why the closure happens basically. Okay. Going back. Yeah, you guys can hear me, right?
Yes,
Okay,
yes,
getting
yeah.
some disturbance. Okay, okay. Um, Again, the mouth, by 1 to 2 months of age, the oral structures are more or less the same. But because of the physiological flexion going away and the physiological hypotonia coming in, the up and down movement of the tongue reduces and it's more of a forward and backward movement. So, your up and down movement of the tongue is basically a sucking movement, and the forward and backward movement that happens is more of a suckling movement. During this time, because the suckling movement starts happening, the infants do tend to lose a little bit of liquid. And again, because of the physiological hypotonia, the lips are not very well sealed. The tongue begins to get a little thin and cupped. And because of the physiological hypotonia which comes in, there is a little more movement in the tongue happening. Although you see that there is a maturation of the rib cage and oral facial musculature, which gives a biomechanical advantage for feeding. So by 3 to 5 months, you see a much better improved postural stability. The head and neck control is so much better, because of which there is better jaw gradation. The tongue is getting a little thinner. The suck pads begin to diminish a little bit, which gives more space and oromotor space. There's an emerging chin tuck with a much more active base of support. The growing maxilla and mandible allow for more space for the tongue, because of which there is greater activity of surface musculature. There is lifting at the central aspect of the tongue. There's flattening, spreading, and emerging dissociation from the jaw. Uh, by around 4 months of age, you will see that the infant generally starts to mouth objects, which is for exploration. And because of better postural control, you see that the drooling sort of reduces by around 5 months. So between 1 to 2 months, because of the physiological hypotonia, that's when your drooling actually starts coming in. And by 5 to 6 months, it reduces quite a bit because of better postural stability. Biting and chewing will start by the end of 5 months. At this time, if you introduce a spoon, in, so what happens is your sucking is a more mature movement, which is the up and down movement of the tongue, and the suckling is sort of a reflex. So when you introduce anything new, so for instance, when you introduce a spoon at 5 months, the infant will suckle on the spoon rather than use all the components to scoop from the spoon. So by 6 months, there's an independent oral control which comes in. The rib cage changes are much more appreciated. There is isolation in the lower lip, and lip closure is much more complete. A little bit of lateral movements of the tongue begin with biting and chewing. And there's a huge variety of jaw, lip, and tongue movements seen by this time. By this time, the sucking movement is much more prominent and the suckling is sort of reducing. And during the suck and swallow, you will see lesser pauses. The base of the tongue is much more stable, which is why there is much better efficiency with breast or bottle feeding. And spoon feeding, the lips are much more active. Um, Around 7 months of age, your responses or reflexes also begin to diminish. Your rooting reflex begins to diminish. Although the sucking will stay on for much more than 1 year, the gag also stays on for a long time. But by around 7 months, your gag response is similar to that of an adult gag response. The jaw movements differentiate from tongue and lip movement in biting. There is graded jaw control which emerges. There are active movements of the tongue, and but there is still not enough strength for the jaw to bite into solid. By around 8 months, you also see a much more mature suck, which is seen. The suck swallow breathing coordination is much better. And even in cup drinking, the infant is able to suck, swallow, and breathe at the same time. There is improved oromotor control with spoon due to increased strength, and they can handle some variety in texture. Again, if you introduce a newer texture, the suckling movement will come in more. Biting is more controlled, but still not efficient enough for solids. Um, by around 9 months, they even, because of the exploration that happens with your oromotor system, the infant will try to have a lot more awareness about texture, size, shape, weight, temperature. So basically, your orosensory also develops a lot by this time. And the forward backward of the movement for swallowing is lesser, and up and down movement of the tongue is more. So by around 1 year of age, everything is improving. There is greater dissociation of oral movements, facial expressions are much more active, tongue movements are much better. There is huge change in the cheeks, lips, and tongue, and the jaw provides for a very active base. There is controlled opening and closing of the jaw. Generally, by this age, the kids are eating almost as well as the toddlers, as in they can eat the toddler food. They can chew on very well on softer textures. They still need a little more help with biting into harder objects. Cup drinking still needs external stability. Spoon feeding is much more efficient, although it may still vary with texture. Lips and cheek are fully active. So I will go on to show you some videos where you will be able to appreciate the movement. Okay, I don't think you'll be able to hear this. So yeah, if you notice here, this is a 4 to 5 month old baby, wherein you can see that the suck pads are still really thick. Uh, if you notice the tongue, it's getting thinner and cupped over here. And then just notice the overall movement that is. I'll just play it once again so that you can notice the tongue over here. See, even in this video, if you notice it, there is not so much of the movement of the tongue happening. It's more of a slight forward, backward movement, even when the baby is laughing. Okay. Next, 1 minute. Again, this is a. So unfortunately, my hand comes in over here, but still, if you can appreciate the spoon feeding. So this is around 6 months. So this is the first time, this is my baby. So this is the first time that we'd introduced solids to my baby. And you can see that it's a new texture because of which there's so much of drooling happening over here. It's not very clear, but you may still be able to appreciate the opening and closing of the mouth. How the upper lip is actually helping a little bit to scoop out from the spoon. You cannot see too much dissociation happening over here between the jaw and the other structures. It's still moving. Not single movements can be seen. I'll just play that once more. Okay. And then, so this is around 1.8. You can appreciate the expressions also over here a little bit. So this is, so there's no spilling, there's no drooling, there's good movement happening. He's a little distracted over here, but look at the expressions. There's good enough facial expressions. And within a span of few seconds, there's been a smile, there's been a weird kind of a frown. So again, I'll just show you the feeding part once again. It's not a good way to feed, believe me, but this is one of the few videos that I had. And then this is by around 2 years of age, where you can see self-feeding and a nice mature eating pattern. There's good use, active use of the lips, active use of the tongue. You can see a lot of movement happening. That's a nice big piece of dosa which he's having. And you can see the dissociation happening between the jaw and the tongue and the lips, everything moving as different units. Okay. So moving on to atypical development. So atypical development, I'll be talking about what are the different atypical components that you will be seeing in the oromotor structure. So one of the first things that you will see is cheek and lip retraction, which we see very commonly in our kids who have hypertonia or dystonia, wherein the cheek is pulling up, the lips are pulling up, and then there's very little movement happening in the cheek and the lip. And because of which, obviously, all the structures become a little stiff and tight. That is why they have so many issues with feeding. You'll see that most kids with hypertonia or dystonia, because of the feeding issues, they lack a lot in their nutrition values. Also, they're very lean and thin. The next thing that you'll see is the exaggerated jaw closure. This generally happens when you're introducing feeding utensils like spoons or cup drinking or something like that, wherein just to provide that extra level of stability, the jaw sort of, you have a big closure of the jaw. This is generally released very easily and it's in their control. It's not that it's an involuntary thing which is happening. Then there is exaggerated tongue protrusion. So what happens is that when you're having the suckling movement or the sucking movement, the tongue doesn't go beyond the lips, it stays within the lips. But what happens in your exaggerated tongue protrusion is that the suckling pattern, what happens is there is increased movement of the tongue beyond the lips, which is what is known as your tongue protrusion. Because of this, the tongue may have a thick appearance, like a bunched appearance. So here what you see is the cheek and lip retraction. This child, somebody has to mute themselves. Thank you. Okay, so this child is cerebral palsy with all four limbs involvement, hypertonic, but there were elements of dystonia also. So you can see a very prominent cheek and lip retraction. The dentition is so bad. There is an overbite. That means the upper portion of the teeth are over the lower portion of the teeth a little too much. You can see very prominent nasolabial folds over here. That is because of the constant pulling that is happening with the cheek muscles. And yes, he's smiling over here, but even in general, if you would look at this kid, he had this constant, expression of a smile even when he was not smiling. The mouth generally stayed open because the lips had been pulled so much. And look at this one, again, a typical baby with Downs. There is, you can clearly see the low tone and the low strength of the musculature over here, the tongue protrusion, thin lips, open mouth posture, reduced nasolabial folds over here because the tone is so low. Then you'll see jaw retraction, which is pulling back of the lower jaw. You'll see jaw thrust, which is a strong downward extension of the lower jaw, which is very high in strength and tension. and it is more than normal of the full opening of the jaw. It is usually they find it very difficult to close the jaw when they need to bite into something or when even when they're talking. Then there is lip pursing, in which the central portion of the lips are sort of semi protruded or puckered, and the cheeks and the lateral aspect of the lips are still a little retracted. So this is the pursing that is seen. This is the protraction. This is the jaw retraction. Then you see tongue retraction, which is a strong pulling back of the tongue into the pharyngeal space. This is particularly a little dangerous also because it could cause a lot of respiratory issues. Swallowing is very difficult. And this is when you could see a lot of aspirations also happening. Then there is tongue thrust, which is forceful protrusion of the tongue from the mouth. And this is sort of a compensation for the tongue retraction. So the tongue is retracted, and when they need to actually use it, there's a tongue thrust which is happening. Basically, the control of the tongue is really poor. Then you see your tonic bite, which is a strong closure of the jaw in response to any tactile input to the biting surfaces. This is generally seen in children with dystonia also. And if you put in a new brush or a spoon, there's such a strong bite. And if you try to pull it out, the bite just gets stronger. So with tonic bites, you just need to wait it out, let the child relax, and then slowly remove the spoon. Don't try to pull it out because that is just going to increase the bite too much. So again, here you can see there is a tongue retraction which is happening, open mouth, overbite, cheek and lips are also retracted. So I'll just show you a video of tongue thrust. Okay. It will come in just about now. See, see that as she's trying to articulate, as she's trying to talk, you can see the tongue coming out of the lips. Let me just show that to you again. Yes, that's it. There. See it once again. Let's see, that's it. That's about your tongue thrust. Then a weak suck, wherein the sucking or suckling pattern in which the nipple can be pulled away from the mouth very easily. This again is seen in your kids with low tone, wherein even though they are hungry, the grasp is really weak, and they get, because of the extra use or the overuse of the muscles, they get tired very soon, they get fatigued very soon, and then it's even more evident that they could just let go of the nipple very easily. I have a video for that also. I'll show it to you. So see, the baby is, and just letting go of the nipple. So this is a baby with Down syndrome. So what are the things that you would see in hypotonia? You'll see a poor lip closure. There is mouth opening secondary to poor jaw strength, decreased inner cheek and tongue movements. There is no dissociation. The tongue works as a whole unit, and the tongue does not help in the shaping of the palate, and hence they remain mouth breathers. In ataxia, obviously because of the incoordination, they will anyways be messy eaters. They stuff their mouth as the coordination is slow and poor. They find it very difficult to grade textured food. The freedom of movement in the mouth is reduced. There's reduced strength and mobility of the tongue, and they hold their lip against the teeth. Again, this is sort of more for stability that they're trying to seek. In apoptosis, they use their mouth for stability. Actually, most of the kids will try and use their mouth for stability in some form or the other. They could either be clenching their teeth, uh, just there'll be an overflow which will be seen. They sort of initiate from the mouth most of the time. They will fix with the jaw, which severely affects their articulation. Teeth grinding may be there, and excessive drooling is seen. Even with hypotonia, because of their open mouth posture, you will see that there's a lot of drooling happening. Oromotor in hypertonia, they initiate the activity with their mouth, an overflow is seen. There's a huge amount of tongue, cheek, lip retraction, which causes difficulty with biting and chewing and swallowing, again causing poor nutrition. There is difficulty in articulation and speech. I'll just show you a video for this one. So just sort of appreciate the movements of the lip that you can see. I know you can't hear it, but see there's a slight overflow. There's an overuse of the muscles over here. They're already pulled back. You cannot hear the video, otherwise you could actually see that the tongue use is so less because the clarity in speech is not very great. See, there's just the tongue is just sitting there actually. It's hardly even moving. See, even the lip movement is so less. He's usually in an open mouth posture. There is an overbite, which is very slight. It's not too much. And there's a slight latency in all the movements which is coming in. Even when he's talking, there's no complete lip closure which is happening. And you can see the breathing changes. He's getting tired because of the overuse of the muscles that is happening over here, even though he's just sitting and talking right now. Okay, so moving on to assessment. So obviously you have to consider all the systems when you're talking, although your more focus is going to be on the oromotor, but you need to know what on the oromotor, you need to know what the other systems are doing, your neuromotor, your musculoskeletal, respiratory, nutrition, GI, cardiovascular. You need to take a good case history. What was the medical history? What was the feeding and respiratory history? What are the current feeding difficulties? The posture and movement. How is the head and trunk control? The posture assumed for the function. What is the influence of the posture on oromotor movement? How is the alignment, the base of support, center of mass? Everything needs to be into consideration. You will need to check on the reflexes, that is the rooting, the gag, the bite. You need to see the general appearance of the oral structures, the dentition. Is there an overbite? Is there an underbite? How is the maxilla? How is the mandible? Is there a high arched palate or a low arched palate? How is the appearance of the lips? Is there a good range of motion which is seen? Are the movement patterns good? Are there any deviations seen? Is the efficiency good? Are there any compensations coming in? How is the structure of the tongue, the tone, the appearance? Is there flattening? Is there too much spreading? Is there thickening? Is there a variety of movement which is seen? Is there isolation of the tongue from the lips and jaw? How is the symmetry and structure and strength of the jaw, the endurance, the variety of movements, and the stability? How are the expressions? Is there grimacing? Is there a continual smile which comes in? Do the expressions change with movement? Are the expressions appropriate to the situation? How is the reaction to environment with respect to sensory awareness and prop? How are the perioral sensations, the intraoral sensations? Is there hyposensitivity? Is there hypersensitivity? How is it versus food and non-food? How is the drooling? In feeding, you will see in which position the child is generally fed. What is the sequence? Is the child able to anticipate the food? What is the reaction to the anticipation of food that is happening? Is there movement of the food? Is there proper swallowing? How is the sucking and drinking? How is the bite, the chew, and in spoon feeding? So the principles of oral movement are very similar to the principles of any kind of therapy in NDT. That is, the muscles need to be lengthened in order to use them efficiently. The postural control serves as a basis for the movement and function. The progression is from global to refined. You'll see that you'll have to start slow and then refine all the movements slowly. There should be gradual dissociation of the movement. Oral treatment is basically inhibition with facilitation with graded stimulation. You're going to inhibit the exaggerated oral reflexes. You're going to facilitate a good swallow, good movement of the oromotor structures, and you're going to have a graded stimulation of the lips, the tongue, and the jaw movement. Basically, you need to normalize the oral area for a good tactile input. So one of the first treatment strategies or the first things that you see in oromotor treatment is giving a good oral control, wherein you're supporting the structures when needed, you're inhibiting the unwanted movements, and you're facilitating the movements that you want. So this is one of the first techniques of oral control. I will just try and get my son so that I can show it on him. If he doesn't come, then I'll just show it on myself. So just give me a minute, please. I'm gonna let you go.
You will not let me go.
I will let you go. Okay, you're gonna be a teacher right now. Okay. So this is my son. Okay. And I'm not gonna put my fingers inside your mouth. I was actually trying to. I wanted him to use for the demonstrations today. So yesterday I tried putting my fingers in his mouth, so that's why he's covering his mouth right now. I'm not putting my finger in your mouth. Keep it down. Okay. So the first oral control is maximal inhibition, wherein your middle finger. So usually I will sit behind the child like this, making sure that he's well supported. Okay. Even if there is a head hyperextension, so my body is here to support. If the child throws back, I'm giving the child a good boundary. And this basically helps me to be in a very good position. Okay. So the first one is the maximal inhibition, wherein the middle finger will be below the chin. Don't worry, I'm not gonna help you. Okay. So this is below the chin. And the index finger is going to be just below the lower lip. Okay. So the index finger will help in jaw, facilitate graded jaw opening, and it also helps in control. And the middle finger is going to help in giving a good base of support for the tongue over here, and also for inhibiting the jaw opening. Okay. The thumb can basically rest on this side or be on the index finger. So if I'm sitting in front of the mirror, this is my oral control, and my this hand is free to do the movement. Okay. So this is maximal inhibition. Just one more thing I need to show. From this side, this is for slightly older children or children who have much better postural control, wherein you're just using. Okay, so you're just gonna place your thumb under the chin, and the other fingers. In fact, let me show this to you. The other fingers are gonna be on the sternum. Okay, so here with my other fingers, I can give a downward input into the rib cage, and the thumb is just under the chin, providing jaw stability only. So this is for children who have better postural control. Again, this hand is free to do the movement. Last one. Okay. And this one, you need to say something. You don't need to see anyone over here. Come. Look this. Sit down. Sit down. They need to see you. Sit down. Sit down. Sit down. Okay. So this one is again for older children and children who have much better postural control, wherein your middle finger is just.
What is that?
That's the earphone. Okay, so your middle finger is just under the chin, stabilizing the jaw, and your, can you please look this side? This last one, and then you're done. Okay, so middle finger is just under the chin over here, and the thumb is on the chin. Okay, again, your index finger is just resting over here. This will help in opening, and this will help in closing as and when needed. Okay, so as I said, this is for much older children. So this is how you will use your other free hand. Okay, so I'm just gonna give him back and come. Thank you so much. Thank you. Okay, so once again, I'm just gonna show it to you on myself. The middle finger is below the chin, and the index finger is just between the lower lip and the chin. Okay, this is maximal control. If you guys can just practice it with me, it will be much better. I can't see most of you. Yes, okay, but just go ahead and practice it with me.
Video
Okay, so
for the people
hello.
at your videos.
No, I don't need it. It's okay, but just they can practice it with me. Okay, so the middle finger below the chin, index finger between lower lip and chin. The thumb can rest on the index finger or on the cheek. Okay, so the index finger can facilitate a graded jaw opening. So just imagine you're giving a spoon or you're giving a chewy tube. And the middle finger can inhibit the jaw opening or control the jaw opening and also facilitate the jaw closure. Okay, from the side, this one, wherein the thumb is just under the chin and the other fingers are resting on the chest area on the sternum, giving a nice downward input into the rib cage, and the thumb provides jaw stability. And this one is from the front. The benefit is that you can give a nice eye contact to the child. The child has much more confidence in you, but it requires much more control and stability from the child. So the middle finger is under the chin and the thumb is over the chin. Okay. Great. So let's move forward. So preparation of cheek and lip musculature. You need to give an appropriate sensory input with respect to tactile, pressure, temperature, and vibration. You need to encourage elongation of the cheek and lip musculature. The tactile can be provided by using a washcloth, a towel, or the bib. Start with moderate pressure and then move into firm pressure if the child is responding well to your cues. Okay, so this is one of the ways to give a nice tactile and pressure input. I'm just going to show it on one side of the face first. So this is the first one. If you see, all the strokes are going towards the lips, more towards the closure of the upper lip and the lower lip. So you start from the side, just around, just below the ear or just around the level of the ear, and then you come towards the lip. Okay, so you can actually do this on one side or you can do it together. Okay, the second stroke is from the, I'm just going to reduce this a little so that you can see it clearly. From the upper aspect of the nose, again coming to the lower lip. Once you guys, if you guys are doing it with me, you will actually feel so much better. You feel so much aware about your cheek muscles. You can feel the elongation happening. Okay, then the second one for the lower lip is from the chin and upwards towards the lips. And the third one is again in a diagonal fashion, coming towards the upper lip and diagonal, going to the lower lip. So if I need to do it on a child, I'll go with 1, 2, 3, 3. Okay, so these are basically giving it. You can't call it a massage exactly because you're going to do it with the towel. You're going to give it a nice tactile and prop input, preparing and elongating the cheek muscles. Okay, so now for the gums, I'm going to put in my glove. Those who are comfortable using just your fingers, you can actually just use your fingers because you're not just going to do it on yourself. I prefer wearing the gloves. So this is basically again giving input into the gums and preparing the gums for either feeding or preparing the gums before articulation. Okay, so you need to have a good local oral control and a good central control. Make sure the child is well positioned, good stability, good postural control. You need to wait for the swallow and then you need to repeat on the other side. Okay, so for the gums, begin with the upper gums, begin with the less involved side. The upper gums basically because they are a little less sensitive than the lower gums. For hypersensitive kids, you need to do just one excursion and it should be firm. See how they're responding and then you can move up to 2 or 3 excursions. And for hyposensitive kids, the touch should be lighter with a slower speed. So for gums, this is how it's going to be. So first, obviously, you need to have a good oral control. And then 1, 2, 3, swallow. So you're going to go back on the gum, come to the midline, go back, come to the midline, go back, come to the midline. 3 excursions, remove your finger, let the child swallow. Okay. Similarly, for the other side, 1, 2, 3, swallow. Then go lower, 1, 2, 3, swallow. 1, 2, 3, swallow. So basically, one side, 3 excursions, remove finger, let the child swallow. Wait a minute, not a minute, wait for some time. Go on the other side, 3 excursions, remove your finger, swallow, then the lower, swallow, other side, swallow. So you'll have to keep noticing how the child is responding and accordingly change if needed. Now inside the teeth for the palate, okay, just whatever possible, keep on going with me. When I'm demonstrating, try and be with me. Okay, so now for inside the teeth for the palate, you need to go back on the hard palate as much as possible, but without eliciting a gagging. Normally, it's all the way back on the hard palate, but depends on child sensitivity. Again, wait for a swallow. You will start with 1 excursion, then allowed to swallow, and then slowly move up to 3 excursions. So for the hard palate, it's going to be you go back on the hard palate, give a nice firm stroke, and come forward. Remove your finger, swallow. Go back, then go around the edge of the teeth on the other side, remove, swallow. Then the other side of the teeth, remove, swallow. So if you try this on yourself, you'll see that the moment you give the first stroke, your tongue literally wants to lift up. So this is very good technique to actually sort of get the tongue also to move a little bit, apart from helping in the sensitization of the palate. So I'll just show you. 1, swallow. Again, you have to maintain oral control at all times. Swallow. So I went 1 straight, 1 on the left side, 1 on the right side. Okay. Now for the tongue, Begin at the front of the tongue at the midline and then literally walk the fingers back, pressing firmly 3 times. Then take the finger out and let the child swallow. The goal is to basically move back on the tongue as much as possible and begin with one press at a time if the gag is happening earlier. So with the tongue, it's going to be swallow. Okay. 1, 2, 3. Front, middle, back, remove, swallow. Now, for hypertonic oral area, you will mostly see that there is cheek and lip retraction, lingual retraction, bunching, which is happening. Maintain a good oral control. Now, here, what you're going to do is because of the cheek and lip retraction, it's going to be like this. So, you're going to use 2 fingers, put one finger in, hold some up, and give a pull. Okay. So, your index finger goes in, your middle finger stays up. If you want, you can add vibrations also over here. Okay. Similarly, on the other side, lower lip, you can use your thumb. Again, the index finger goes in. Closure. So again, here also you can do this around 2 to 3 times, 2 to 3 times, 2 to 3 times, 2 to 3 times. Swallow. In between each excursion, there's going to be a swallow. So you do this one, remove, swallow. Do it again, remove, swallow. Then you can take a nice towel and again, causing more closure of the lip, good elongation of the muscle. For lingual retraction, again, what you could do is take the finger, keep it on the middle of the tongue, and give a nice straight stroke, sort of elongating the tongue. If it is possible, you could actually hold the tongue and give a little pull. The kids with hypertonia usually have a really thick and bunched tongue, so holding it could be a little difficult, but as and when possible, make sure that you're not pinching onto it, let it be firm, and then give a slight pressure and then pull onto the tongue a little bit. For hypotonic oral area, for hypotonic cheeks, the child is in supine, the therapist is besides the child, and basically you're going to give a nice, it's not a slap, it's more of a tap. You should not hurt the child, so it's like 1, 2, 3, sort of waking up the muscles over here. For the tongue, again, you can use 2 fingers, keep it on the tongue, slight vibrations, and again, elongation. You could also use the 2 fingers and sort of help in spreading the tongue. You're going to go like this. Okay, so kind of more spreading and kind of giving a slight cupping that should be there in the tongue. So this is for the hypotonic oral area. Now, this is just a nice image that I found for feeding in CP. You can appreciate that the child is in a very nice position, well supported, head and neck are well supported. There's a good oral control. There's a good oral control given by the therapist over here. The spoon is low. She's approaching from the midline as she's going. So if the child can see what's there in the spoon, the child can have a good anticipation of what is going to happen. Now, face wiping, it provides a generalized oral stimulation and it helps to prepare the oral motor structures, basically giving a good sensory normalization. It helps in elongation of lip and cheek and mid-face musculature. So actually, this is a very nice technique which can be taught to the parents also. So if you notice, whenever there's some drooling happening or something happening, the parents just, it's a very light stroke and they just remove it off. Instead, you could actually tell the parents, give a nice sensory deep pressure and then wipe off the drool. If it's on the lower lip, give a nice lip closure and then wipe off the drool. So these are just some techniques which are, I'm telling you just for more of your awareness rather than actually putting into practice, because this generally is taken care of by the speech therapist. But just for your knowledge. So in bottle feeding, make sure that you approach the bottle from midline and below. Facilitate a graded jaw opening. Put pressure on the tongue with the nipple so that there is a good stimulation for sucking. Spoon feeding, again, begin with a closed jaw. The spoon should be approached from low to midline. There should be a graded jaw opening. Put the spoon straight in and press down and flat on the tongue. Hold there for a moment. See if the child is using the lips actively to scoop out the spoon. And then get the spoon straight out, not in any angle. And make sure you're not scraping on the upper lip or the teeth. Cup drinking, begin with the jaw and lip closure. Tip the cup direct so that the liquid is directed towards the rim. The cup again should be approached from midline and from below. Make sure the cup is not placed between the teeth. It should rest on the lower lip. Tilt the cup a little so that the liquid reaches the lower lip, and then wait. The goal is that there should be active movement of the upper lip to draw the liquid inside. Don't remove the cup in between the swallows, and maintain an oral control throughout. So this is a very nice picture which is showing how cup drinking should be done. These cups are amazing to train the children for drinking. These, I think, are available freely in India also. If not, you could actually just take a paper cup or a plastic cup, cut it out, and then use that. Make sure the edges are rounded so that it doesn't hurt the child. Biting and chewing, begin with meltable solid consistencies and smaller portions. Provide a good oral control to inhibit jaw extension. Provide a slight downward pressure with the solid upon the biting surface, and then facilitate oral closure for the bite. Maintain a good oral control. So these are some of the things that can be used: the P's and the Q's and the chewy tubes, the T tubes, the key tubes. And then this is something which I found is very nice because it doesn't overwhelm the child with the amount of object that is coming into the mouth. The child knows that, okay, I just need to take a small bite. So it helps big time. So drooling and teeth grinding are something which do not have a particular cause, actually. It could be because of anything wrong with the development. So drooling is typical from 2 to 5 months. Beyond that also, it can happen many of the times. And atypically, it could happen because of your low tone, because of open mouth, because of low tone in the tongue, because of the low muscle strength. So you cannot per se treat drooling. You need to make sure that all the other components are set right, and automatically the drooling will reduce. Similar with teeth grinding is also typically seen till the age of around 2 to 3 years old. And also teeth grinding is something which can happen during dentition. It can happen if the child is not well. It happens if the child is a little stressed. It happens if the child is prop seeking to just gain that stability. So again, a lot of articles that I read said that there's not anything that you can do particularly for teeth grinding. All the oromotor, perioral stimulations don't work so much. A vibratory brush can work really well for teeth grinding because it helps provide that prop which is needed. And a little bit of stimulation and working on the other structures will help much better. So this is in general about drooling and teeth grinding. And we're almost at the end of our presentation now. So if you have any questions, doubts, clarifications, please let me know.